Hello everyone, I'm Dr. Divya, second year radiodiagnosis junior resident at AIMS BB Nagar. I'm going to present an interesting pediatric radiology case evaluated in our department. So, this was a case of a 1-year-old male child who presented to the pediatric surgery OPD with complaints of swelling in the left foot since 5 months. And this swelling was predominantly involving the left great toe, and it was also associated with difficulty in walking. On examination, this was a rather ill-defined swelling, firm in consistency and non-tender, and was seen extending from the left great toe to the heel, involving the dorsum of the foot. So then this patient was referred to our department for AP and lateral radiographs of the left foot. So in the skeletally immature radiograph, we found that there was an lobulated increased soft tissue density noted in the first interdigital web space with focal areas of lucency within, likely representing the fat within the soft tissues, and the swelling was also seen causing widening of the first interdigital web space. However, there was no evidence of any calcifications noted within the soft tissue, and the adjacent bones appeared normal with normal alignment and normal morphology. So, based on these findings of localized soft tissue overgrowth causing widening of the first interdigital web space, we would keep the DDs as macrodystrophia lipomatosa, considering the focal areas of fat within. Another DD that we could think of was neurofibromatosis and also vascular malformations such as hemangiomas and arteriovenous malformations. So then the patient was referred to our department for MRI evaluation. On MRI, we found that there was a focal lobulated T1, T2 hyperintense soft tissue overgrowth, which was seen causing widening of the first interdigital web space. And the lobulated soft tissue overgrowth was also seen involving the plantar aspect of the first and second toes of the left foot. And this localized soft tissue overgrowth showed suppression on fat SAT sequences, and there was no evidence of diffusion restriction noted within this soft tissue overgrowth. There was no evidence of any well-defined capsule or calcifications or focal osseous mass noted within the soft tissue overgrowth, and there was no evidence of any macrodactyly noted in any of the digits, and no evidence of any flow voids within the lesion or cartilaginous abnormality noted within the involved structures. So, based on these findings on MRI, the diagnosis of this soft tissue, localized soft tissue overgrowth would be macrodystrophia lipomatosa. Macrodystrophia lipomatosa is a rare congenital anomaly characterized by abnormal overgrowth of the mesenchymal elements resulting in gigantism of single or multiple digits or of the entire limb. The age of presentation is inconsistent and the clinical findings can be recognized as early as in the neonatal period to late adulthood. Although there is no gender predilection, slight male preponderance is seen. Generally, the lateral aspect of the upper limbs, that is along the median nerve distribution, and the medial aspect of the lower limb, that is along the plantar nerve distribution, are affected. Lower limbs are generally more affected than the upper limbs, and the second and third digits are commonly affected. The affected region continues to grow until puberty, after which it reaches a plateau. Other associated findings that are noted are lipomatous growths in intestines and in other tissues, calvarial abnormalities, pigmented nevus, pulmonary cysts, syndactyly, polydactyly, brachydactyly, and symphalangism, as can be seen in macrodystrophia lipomatosa. Bilateral involvement is very rare in this condition. Plain radiographs are the first and most commonly used modality where findings such as soft tissue overgrowth with osseous hypertrophy of the affected digit or limb can be seen. Osseous changes are increased length, width, and cortical thickening of the underlying bones. In digits, these changes are usually seen along the volar aspect leading to dorsal bending. Bony outgrowths with or without degenerative changes in the adjacent joints can also be ascendant, and in long-standing cases there may be ankylosis. MRI is used for problem solving and it helps to distinguish macrodystrophia lipomatosa from other causes of macrodactyly. It demonstrates accumulation of fat in the subcutaneous tissues without a discernible capsule. There might be fibrous strands seen within this accumulated fat with cortical thickening, osseous hypertrophy, and bony outgrowths from the underlying bone. Neural thickening may also be visualized. Usually the intervention is carried out due to cosmetic reasons, but the guiding surgical principle in managing this condition should be improving cosmetic appearance as well as preserving the neurologic function. The surgical treatment is quite a challenge because despite the removal of adequate tissue, the difference in size may not be very apparent. And the incidence of nerve injury following extensive debulking or lesion removal is approximately 30 to 50%, with high recurrence rates of 33 to 60%. So this concludes my presentation. We hope you all enjoyed learning about this rare entity of macrodystrophy lipomatosa. Thank you all for watching and stay tuned for more videos.